Hello, good afternoon. This is Dr. Ramesh Sachdeva, and on behalf of VPS, I would like to welcome all our participants this afternoon for the Research Spotlight. We have an exciting paper and some findings to discuss related to characteristics and outcomes of critically ill children with multisystem inflammatory syndrome. To present these findings, we have two of the lead authors from this paper, Dr. Kelly Snooks and Dr. Matt Scanlon. I think both of them don't need any introduction, but I'll try to quickly summarize them to welcome them before they get started and I hand the podium to them. Dr. Scanlon, Matt and I have had a long track together. We worked together for many years when I was in Milwaukee. Dr. Scanlon currently is the professor of pediatrics and critical care at the Medical College of Wisconsin and the co-director for quality improvement and patient safety pathway. Matt's has had an illustrious career in the patient safety space, having served in many roles, including as the patient safety officer. He also has completed additional training in systems engineering, a very unique area from University of Wisconsin, which he has very successfully blended into the patient safety arena. Matt also serves as the Associate Chief of Critical Care Medicine Operations. So Matt, it's great to have you present this afternoon. Along with Matt, we have Dr. Kelly Snooks, who's the lead author for this paper. Kelly is a faculty assistant professor of pediatrics and critical care intensivist at the Medical College of Wisconsin and Children's Hospital of Wisconsin. Kelly has a very interesting background, including completing an MPH. And interestingly, Kelly's, I think, spanned the MPH continuum from research activities in the area of sepsis on one hand to community health efforts in the other. Indeed, a full application of MPH. Also, I was impressed, Dr. Snooks, reading a lot about your work in the global health arena and how you bring it into the critical care forefront. So with that, I'm going to hand it over to Kelly and Matt. I think MISC and the COVID pandemic is not unique to any one area. It impacts all of us at a global level. So without any delay, Kelly, hand it over to you.
Yes, thank you so much. I'm going to go ahead and share my screen. All right, you guys can see my slides okay? Perfect.
Yes, that's good.
Okay, great. Thank you guys so much for having me. As was mentioned, I am an assistant professor at the Medical College of Wisconsin and attending in peds critical care at Children's Wisconsin. This project was really a collaborative effort with a lot of co-authors on there who I have listed at the end here. So we'll present our characteristics and outcomes of critically ill children with multisystem inflammatory syndrome. This was published as an online brief report in 2022 for pediatric critical care medicine. So a little bit of background information, because I feel like it maybe has been a while since some people have seen MISC, but MISC is a severe illness that's associated with SARS-CoV-2, and it's caused by a dysregulated host immune response following an infection with SARS-CoV-2. It presents with multisystem organ dysfunction and has a wide range of illness, severity, and symptoms. Criteria for diagnosis did change, but at the time of this project, it was fever, evidence of a COVID infection or known exposure, more than 2 organ systems involved, such as mucocutaneous, gastrointestinal, respiratory, neuro, etc. It was reported that anywhere from 14 to 74% of patients with MISC required PICU admission. At the time of our project, there was no comprehensive longitudinal study of the characteristics and outcomes of critically ill children with MISC across the United States. Additionally, we knew strain variant change throughout the course of the pandemic, and the relationship of the prevalence of MISC to strain variant remained unclear. For this, we sought to characterize the prevalence and outcomes of MISC in critically ill children using the VPS database and to assess the influence of SARS-CoV-2 strain on outcomes. We performed a retrospective analysis of prospectively collected data that was entered into the VPS database. Our inclusion criteria was children under 18 years old with a primary diagnosis of MISC. They were admitted to the PICUs from January 1 of 2020 to June 30th of 2021. The data was anonymized and divided into quarters. Quarter 1 is defined from January 1 to March 31st, quarter 2, April 1st to June 30th, quarter 3, July 1st to September 30th, and then quarter 4, October 1st to December 31st. We analyzed demographics, severity of illness, supportive treatments, and outcomes. Statistics were performed using SAS software. Median and interquartile ranges were calculated for continuous variables, and frequencies were calculated for categorical variables. Quarters were compared using the Pearson's chi-square or Fisher exact test when n was less than 5 for categorical data, and then the Kruskal-Wallis for continuous data. With our results, we had 145,580 children admitted to 115 PICUs between quarter 1 of 2020 and quarter 2 of 2021. Only 0.9% of those patients, or 1,338, had MIS-C as a primary diagnosis. What we noted was quarter 1 of 2021 had the most patients, with 626 patients having a primary diagnosis of MIS-C. That had accounted for 2.7% of PICU admissions at that time. 61% of all quarters were male, and 41.9% were ages 6 to 12 years. Adolescents that were 12 to 18 years old comprised 34.4% of cases, and only 2 neonates were diagnosed with MIS-C throughout all the quarters. Other notable findings were that 62.3% were admitted from the ED, and then 30% were transferred into PICUs from the general care floor. There was a low probability of mortality on admission, with a median PIM-2 score of 1.15 across all quarters. This is just a snippet of Table 1. Table 1 had a lot of information in it. Of note, when looking at this, we only had 1 patient that was admitted in quarter 1 of 2020, so they were omitted from the table. Again, the data regarding viral strain predominance was obtained from the CDC. As you can see here, the original SARS-CoV-2 strain and the D614G strain were the predominant strains throughout 2020. In quarter 1 and quarter 2 of 2021, the predominant strain then shifted to the alpha B117. As mentioned in the previous slide, we can see here that quarter 1 of 2021 had the highest number of MIS-C admissions, which accounted for 626 patients, or 2.7% of admissions for that quarter. Overall, the median PICU length of stay for patients with MIS-C was 2.7 days, and the median hospital length of stay was 6.6 days. Both the median PICU and hospital length of stay per quarter decreased over the study period, with a significant decrease occurring between quarter 3 and quarter 4 of 2020 for a p-value of less than 0.0001. Overall, 15.2% of MIS-C patients received mechanical ventilation for a median of 3.1 days. The frequency of mechanical ventilation decreased over the study period as well, again with a significant decrease occurring between quarter 3 and quarter 4 of 2020, a p-value of that of 0.001. Overall, ECMO remained low throughout all quarters, with only 13 patients, or 1%, requiring ECMO, and hospital mortality was also low, with 11 total deaths, or 0.8%. This figure here, again, just kind of makes a nice visualization of the data that was in the table. The blue bars represent the hospital length of stay, and the red represent the PICU length of stay, and their associated 25 to 75% IQRs and range. The black line represents the percent intubated per quarter. As you can see, the significant decrease here in the percent intubated was between quarter 3 and quarter 4 of 2020, and it remained low over quarter 1 and quarter 2 of 2021. For the hospital and PICU length of stays, we can see that same trend as well, with a drop off in the quarter 4 of 2020, and it remains low for quarter 1 and 2 of 2021. So to our knowledge, at the time of this publication, this was the largest cohort of critically ill MIS-C patients to date. We noted that although mortality was low, there was a high disease burden, with a high median hospital stay of almost a week and a median ICU length of stay of almost 3 days. And as we saw, more than 15% of children received mechanical ventilation. There was a significant decrease in the length of stay and the frequency of intubation between quarter 3 and quarter 4 of 2020. The driving factors for this decrease are unclear, and they might be multifactorial, possibly due to an improvement in therapeutic interventions, improved recognition of the disease, availability of antibody testing, occurrence of milder disease over time, or some combination of all of these. As we had seen, the predominant viral strains shifted in Q1 of 2020, but this appeared to be after an improvement in outcomes. So although Q1 of 2020 had the highest number of MIS-C patients, that also coincided with a large peak of COVID infections in the US, it's possible that either illness severity from MIS-C decreased with that strain or that we had improved therapeutic interventions. I think it's important to note that around this time as well, there was a rapid improvement in outcomes, probably due to the rapid growth in the understanding of MIS-C. This included the American College of Rheumatology consensus guidelines for the treatment of MIS-C that were published in June of 2020, and those were modified in October of 2020. Given the timing of the different viral strains, it's more likely that an improved understanding of MIS-C was the explanation for the improvement in outcomes. So as with any study, this was an observational retrospective study, which is one of its limitations. Another limitation was that medication data was unavailable, so we were unable to assess if outcomes were due to differences in management. And also because our data was analyzed by quarter, we were unable to conduct a more granular analysis for admission dates that might have been correlating between peaks of MIS-C in relation to the different strains of SARS-CoV-2. So in conclusion, there was a low mortality, but hospitalization and illness burden was significant for MIS-C. There was a peak in MIS-C in Q1 of 2021, which coincided with a peak in COVID infections and a shift in viral strains. However, improvements in MIS-C outcomes started prior to this shift, suggesting that viral strain was not the driving factor for the outcomes. Now, that was short, but I want to say thank you to all of my co-authors here for all of their help. This was really a collaborative effort. And we will take questions at this time. If anybody needs to, there is a scan for the PDF there.
Yeah, thank you, Dr. Snooks, for that very exciting summary. I think it's a really important study, and also appreciate yours and all your entire team, all the co-authors, outstanding work to move this field forward. I don't know if Matt, if you have anything else to add at this point. I do have one or two questions to start the discussion, but Matt, anything else from your side you'd like to add?
No, Kelly did a great job, as I would expect.
Excellent. So, Kelly, I just had a question for you. I know when you look at the data, I know there's a drop in the mechanical ventilation, and I know you've provided some possible reasons why that could occur. Are there any more recent data outside the study that you have looked at, either at your own center or other experiences, like what's happening more recently? Has that improvement trend continued, or where do things stand?
Yeah, I mean, I can just say clinically, I haven't looked to see if there's any recent data, but I can say clinically, I don't think I've seen an MIS-C patient in months. I don't know if anybody else has any different thoughts, but I think honestly, after we had finished this and completed this, I think the MIS-C burden had significantly decreased around the same time. So I didn't see anything else. I don't know if Matt has anything. Yeah.
Yeah, that's a good point. Any questions from the audience, from the participants? Please raise your hand, or you can just jump in. Vanessa, people can ask directly, right? They don't need to, you don't need to do anything on your end technically. They can just ask the question.
The best thing to do is please use the QA box at the bottom of Zoom, and then
so there's a QA box right at the bottom. You can please put your question in that, or you can obviously raise your hand, and we'll get to you. So, so Kelly, Matt, while the audience are thinking of some questions, one other thing which always comes to mind is that in this sort of a study, especially with the changing course of the pandemic, there are these pockets of, reports coming out with some COVID numbers increasing in certain areas. Do you all have any future plans as to what would happen next with the study, or what can others listening to this discussion, what should others be looking for from a research standpoint?
I think the one thing that would be interesting, I mentioned it in the limitations there, but it would be interesting to compare treatment because I think that treatment was probably different depending on institution and things along those lines. So looking at outcomes versus what the treatment was utilized, I think would be interesting. We didn't have that data with this data set, but that would be something of interest, I think. Yeah,
that's a very good point. And how do you go about doing that? Like if somebody wanted to do that, what would you suggest as the lead author? What have you learned from your study that others can benefit from if they want to go in that direction, Kelly?
That's a great question. I'm not sure where that data would be available, but I mean, thinking of steroid use, IVIG, we also utilized aspirin. Towards the end, we had a few patients that needed to use, immunomodulators or anakinra or something along those lines. So it would be interesting to look at the long-term outcomes of these patients with the treatment that they received.
Indeed.
Ramesh, if I could add
Yep,
on that,
of
I
course.
think as the planned collaboration and linkage between VPS and Fizz becomes available, there would be the possibility to look at a granular level at treatments by PICU patient to then better discern were there significant differences. So just thinking of the future, that would be the best strategy, I think.
Great, good suggestions. Good suggestions. That's great. We do have a question from the audience. Dr. Barry Markowitz has a question. You can look it up in the Q&A, but Barry, thanks for your complimenting the team, the study team, for their nice work and presentation. Dr. Markowitz's question is it possible that the strains that children were seeing did not particularly track the CDC predominant strain? There's something different here. And hard to see how recognition would prevent respiratory failure. So that's an interesting question. Any thoughts, Dr. Snooks, Dr. Scanlon?
I think I maybe have two. The predominant strain, it was hard. And again, we looked at everything by quarters rather than by date of admission. So if we remember with MISC, the peak of these patients presenting was originally 4 to 6 weeks after any sort of COVID exposure or infection. So I think it was really hard to tell us which strain, especially in the shift there, was the predominant strain that was being seen. I think when we started to recognize MISC sooner, was there a higher inclination or a sooner inclination to start steroids, which maybe could have prevented some of the respiratory failure that we were seeing? I think, again, that's hard to say. That would be another area where the data looking at the treatment modalities might be helpful.
Indeed.
Matt,
yeah. Matt, anything to add there?
I just wonder about other comorbidities that I don't know that we dug into to say were there cofactors for the kids that had respiratory failure versus not. I know we had a wide range in who presented with MISC, and certainly some of those children were less healthy than others. So that could be a factor. But I think his point is correct, that it's certainly possible that the predominant strain wasn't what was getting these kids sick. I don't know that all the VPS participants submitted data on the identification of those substrains that was archived somewhere at the CDC. That would be another question to explore.
Yeah, good points. Really good points. We have another question from Maria from California, and the question is, would the treatment data be available through an infectious disease group? So Matt, I know you talked about Fizz, but this is, I think, augmenting that comment. Could we go to an ID group to get additional data?
I am skeptical, and I say that because in our center, once ID weighed in on our approach, they largely dissociated themselves and left it to the intensivists and rheumatologists. So I think one of the things we'd have to start exploring is, what is the variation in practice management for all the VPS participants? It may be that 70% of the centers, ID was the principal consultant, and then we have to look at how consistent are they internally. One of the things that was frustrating early on was, as our internal MISC guidelines were being updated by Kelly, who did a phenomenal job, often the on-call person wasn't aware of the most recent updates. So we were often provided initial consultation that was not consistent with what we had agreed on as a collective. And so I don't know that any ID group would have a body of data to look to. I don't know that it would represent all the patients involved, and I seriously question whether it would be granular enough to know about variations even between providers.
Yeah, I do know from The one group that did do a lot of long-term follow-up with these patients was actually our cardiology team. And another cardiology group actually was collecting some pretty significant data. I don't know if treatment modalities was in that, but I do know they were the ones to follow them a little bit more long-term, especially at our institution.
Yeah, I know Maria responded to the discussion that acknowledging what you just said, and could look at the other specialties. I think that's what you were talking about, the cardiology issue, right? Good point. Other questions from the audience? Matt, Kelly, one other question I have is, always wondering these sort of very important studies, which are first of their kind in a way, and landmark studies and investigations. If you had to do the study all over again, what would you do different in the design or implementation? And I ask because those could be important points and takeaways for our audience as they embark upon similar endeavors. Anything you would do different?
I think that's hard. Yeah. Matt, did you have something off the top of your head?
Yes, I think that one of the things that was really problematic, and so first of all, I want to echo Kelly's comments about the collaborative group. There was really strength in numbers here, and I think that there's a lot to be said for groups of investigators across the U.S. partnering with, which involves some work of figuring out who's going to take the lead on what project, what are the terms of authorship, because some journals restrict the number of authors. But so there's some practical details, but with the COVID data, one of the things that was problematic was that it presented in different parts of the countries at different times. And so Kelly talked about how we use quarters, but because some places were ahead of others, in fact, if I recall, when we first looked at the data, there was some cases that were in March, and it was because they were likely on the West Coast where we were, or New York, I forget which, that was one of the early centers of it. So I think while we talk about it in the methodology of this paper and some of our other papers that we've done, I think the challenge of normalizing data across different timelines was not necessarily a unique problem, but certainly problematic for our work.
And Matt, sorry, Kelly, go ahead.
No, that's okay. That's exactly what I was going to say. I was going to say maybe looking by exact date rather than quarter might have been a little bit more helpful. And even if we could have broken it down by region, but kind of echoes Matt's points.
And I think,
yeah, go ahead.
Well, I mean, it is the nature of our current data use agreements, and I'm not complaining at all about those, but by virtue of the fact that you cannot get down to granular levels of individual centers, it's really problematic to account for variation. I think that's an ongoing challenge. I'm going to be curious to see how the FIS collaboration deals with that. And I think that, well, I'm hoping it's not in my lifetime. I could see another pandemic just the same, particularly with the philosophies about masking and isolation. So it may be that even with things like measles, and where I expect we will be seeing recurrence if the current vaccine philosophies hold true, and looking at how do we sequence the data across different zones of the US may be a challenge.
Indeed.
Yeah.
And Kelly and Matt, just one final question, just building on the previous comments. I think many of our participants are early career faculty members who may be interested, who are at a center in one part of the country, but are interested in participating in these multi-center studies. You have a list of authors from across the country. How does one go about doing that? What's the path? What advice can you give our early career faculty members to embark on similar endeavors?
Well, Ramesh, speaking specifically to this set of data, there were a couple of investigators that requested data near simultaneously, and I remember I was asked to help broker whether we could collaborate as a larger group, which everyone was very amenable to doing, and again led to a number of work products that I think are important. I think that there's an opportunity, and you know, I've raised this issue offline, or online, I guess, but not publicly, of creating other collaborations not hosted by VPS, because that's not your charge, but at least connecting researchers to explore other topics of shared interest. I think the one that comes most obviously to mind is as social determinants of health data becomes available and could be potentially linked to VPS, how does a center look beyond their local catchment and look nationally? And I think as VPS rolls out plans for addressing that, one of the things to think about is there a way to at least connect investigators who have like interests? Again, not asking VPS to do the statistics to sponsor travel or the meetings, but rather to just connect the community so that you're not the N of one investigator trying to, and especially if your early career and no one at your center is particularly interested in this or doesn't have the skill in VPS research, it's an uphill battle to start without some guidance.
Kelly, your experience through this?
Yeah, I think, you know, as an early career faculty member with this, I think Matt had a lot of guidance in bringing me into the group that was mentioned and working on this. This kind of spanned actually my fellowship into attending hood. So it was a great transition, and I just got lucky that I had mentorship at my own institution. But I do think that, you know, reaching out to, you know, networking at other groups, AAP, Policey, things along those lines is actually, if you don't have somebody at your own institution, is a great opportunity for networking. The one thing I was going to mention, I forgot, when we were talking about if we could do this study differently, you know, the one thing we didn't have, or that was very, I think there was a lot of none answered, was ethnicity and racial information. And there were a lot of health disparities that came in with MISC as well that we weren't able to capture. So I just had that thought in the back of my mind that would be interesting moving forward as well.
Great suggestion. I think that's really important. Any other final questions from the audience? I know we are just about 2 minutes before we are scheduled time to end. Dr. Scanlon, Dr. Snooks, anything else you'd like to add? Any takeaway messages for the audience from your end?
I have nothing, Ramesh. Thank you.
Kelly?
Me either. Thank you so much.
This was very interesting. Thank you for sharing your work with all of us this afternoon. Congratulations on a very successful study. And Vanessa, thank you for organizing this. And thank you to all the VPS staff, and appreciate everyone's time this afternoon. We are right at 4:28 Eastern time. So we'll close here and look forward to having everyone at the next Research Spotlight.
Thank you.
Thank you.
Have a great day.